Hello, welcome all of you. We are very happy that you joined our webinar this evening. I am Piraye Lazar, an adult neurologist, and I will be co-moderating this symposium with my dear colleague, one of the top shoulder orthopedic surgeons, Professor Mehmet Demirhan. We welcome you together, actually. Now, I have to mention that this webinar will not include drug therapies. It will be out of drug therapies. The main focuses will be the challenges in diagnostic areas and a very special type of management, actually, which is called scapulothoracic arthrodesis. So these will be the focus of this meeting, this symposium. Now, just in a few minutes, just go back to 80s. We had been interested in the disease since 1980s as clinicians at the University of Istanbul. With my dear colleagues at that time, Feza Deymer and Yeşim Parman, we were desperately trying to settle down the genetics of difficult genetics of FSHD at that time. We had several attempts, but we were unsuccessful to do this. So what we could do was to follow our patients in a proper way and give physiotherapy to them, exercise therapy. That was all we could do. Now, one day towards mid-1990s, an orthopedic surgeon at Istanbul University, Mehmet Demirhan, approached us. He was a shoulder surgeon, and he was interested in doing scapulothoracic arthrodesis to FSHD patients. We were very surprised, actually. At the beginning, we were not convinced. He convinced us by giving examples of this. We discussed and then we decided to start this. So our collaboration started with Mehmet Demirhan and his team at Istanbul University. Thank God many patients benefited from this surgery. They were benefiting so much that we were very anxious to do the surgery to many of our patients or all of our patients. But of course, they were cautious. They collected a vast amount of database. They returned back how it went on and so on. They did a lot of work on that, and they now selectively do it. Soon after we collaborated, Mehmet Demirhan had a team with İlker at Koç University. So he was doing the surgery there. After 2015, the FSHD genetic studies, these difficult genetic studies, was initiated by Hülya Kayserili and Serpil Erarslan at Koç University. It was very difficult. It was a very difficult era, actually. They put on so much effort, I cannot tell you. But in the end, they finally set up most up-to-date genetic testing system at Koç University. In 2019, I moved to Koç University to establish the muscle center. This is a multidisciplinary muscle center there. So this included our FSHD group, but it was more than that. We within the body of muscle center, we had many other colleagues as well. So the group was finalized after my moving there. We still find it a very interesting disease. And then maybe Mehmet would like to say something about this past. I don't know.
Thank you, Professor Lazar. It's actually a great honor for me to share this webinar together with you and with the genetic department, my dear friend Hülya. Hülya is my class friend from medical school, and with my fellows İlker and Cemil Cihat. As you mentioned already, that when I moved from the Istanbul University to the Koç University, it was 2011, and the Koç University was there, the medical school was there as very, very young, and then we established the medical school, and then I focused together with my fellows about the past research for FSHD in Istanbul University, and then we contact with you, and you established this muscle center. I think this is actually a great step for the muscle disease, not only in Turkey, also in Europe and in the world, because not only in the research and also the medical services was in the first class, and together with the genetic department, with the cardiology, and with the thoracic surgery, and with the orthopedic surgery, and we covered all aspects of the muscle centers. And this is actually in that reason we are the most prominent muscle centers in the Europe, and I think it's just only 3 or 4. And we covered all the aspects of the patients, and including the orthopedic surgery. And the orthopedic surgery and the scapulothoracic arthrodesis for FSHD is actually not a new concept. However, the success of the surgery is in the past not so great. In that reason, it was very conscious about from the neurological side and from neurologists to send the patients for this surgery. And as you mentioned, is actually we developed the new surgical technique. We published this 20 years ago, and then we have the results and the very, very late results. We published this, and then after that, we get the very important point, and we have the new classification for FSHD patients, which patients are they can have the benefit from the surgery and etc. Those are the major steps for the FSHD surgery, and then the surgery cannot actually help in any way. Also the genetic development and those are the most important part of this FSHD service in our Koç University muscle centers. Now, so much from this past history. Probably we have to now start together with Professor Oflazer, and then continue with the genetic department. And this is actually most important part, because the Professor Oflazer will cover this disease, and then the genetic part will be covered Professor Kayserli and Dr. Serpil. Thank you very much.
Hello. Firstly, we would like to thank both of you for your kind words for the medical genetics team. I mean, it's now 10 years that when I first started at Koç University, Mehmet and Dr. Mehmet and Dr. İlker approached me for the FSHD diagnosis before I started to work at Koç University. So we will try to summarize our journey of 10 years in the genetic department for the FSHD diagnosis. So the diagnostic, we are going to talk about diagnostic innovations, but I will try to give a brief summary of what we know about the FSHD genetics, and to understand more in depth about the diagnostic possibilities, and also for the best outcomes for the treatment options of surgery. So I will try to summarize FSHD genetics briefly. There are 2 different types of FSHD, type 1 and type 2. And then at Koç University Hospital, we have also the diagnostic journey of the FSHD plus the research journey. So we will just mention the research projects that we had conducted and we are still conducting. And why did we choose FSHD as one of our main topics, both for diagnostics and also for research? As Dr. Piraye of Lazer has already mentioned, they had, together with Dr. Demirhan, they had a very good clinical cohort and they had a very good collaboration, a well-defined. I mean, we were lucky because we started with a well-defined clinical cohort availability that was gathered over 30 years. And just 2 or 3 years later, the muscle center at Koç University was established. Of course, at the even before the muscle center's establishment, we had a very good teamwork, which is a neuromuscular diseases team. Of course, Dr. Piraye was the had a leading role at all times, and with her young colleagues who are experienced and who are very enthusiastic to learn more in depth about neuromuscular disorders. Geneticists, also our group with the clinical and the molecular laboratory staff, and orthopedic surgeons well experienced on FSHD surgery, cardiologists, ophthalmologists, and physiotherapists. So we know very well from all other neuromuscular diseases that teamwork is essential for the success, both for the patient and for the diagnostic, for the output of the whole team, and also for the best support of the patients on the long run, and to have a very good research, to have a good research output. So these were the good parts why we started our journey of the FSHD. But of course, we knew that there was no diagnostic facility in Turkey and also in other neighboring countries, meaning that we will be the first ones to have a diagnostic facility on this disorder. And of course, from a geneticist point of view, the genetic etiology of FSHD is very complex. So it is challenging by itself to geneticists. So in our journey, not a very long one, about 10 years, now there are only 15 labs in the worldwide offering FSHD genetic testing. 6 in North America, 6 in Europe and UK, and 3 in Asia. And as you can see, the Koç University Hospital Genetic Diseases Evaluation Center is among one of the 15. So we have from a diagnostic point of view, that for performing genetic testing, we have a very good reputation. So why is FSHD so important for us and for all members of our group? Firstly, the FSHD is the third most common neuromuscular disorder. We know this. Of course, there are different prevalence numbers, but we know after Duchenne muscular dystrophy and myotonic dystrophy, Facioscapulohumeral dystrophy is the third one. So there are a lot of patients that needs clinical care and support. So the prevalence of the disease in the latest and the most recent data is about 1 in 8,000. So we know that the prevalence is very high. Of course, for us, the inheritance pattern is very important. The first item is, of course, we know that it is autosomal dominant. While it is autosomal dominant, there are, of course, other issues that need to be taken off for the inheritance pattern. Autosomal dominant inheritance can be in the pedigrees. You can view as a generation in each successive generation. There are new individuals in the successive generations, and we see in the pedigrees the affected in a vertical manner. So, but in some families, there is no one that is affected in the upper generation, and we call this a sporadic case. But when we can do the molecular genetic testing, we do understand that they are de novo cases. So we have the familial and de novo cases. And also we have clinical variability. The clinical variability is both interfamilial and intrafamilial. These are the first notes for an autosomal dominant inheritance. But for the penetrance issues, we know that 30 years of age, only 83% of the patients do show the symptoms of the disease. And males have a penetrance, a higher penetrance, and females have a lower penetrance. And there had been several research projects already performed on it. Secondly, there's a inheritance pattern, diagenic inheritance. Diagenic meaning that two different genes are contributing to the phenotype. There are two gene loci that are contributing to the phenotype. So for FSHD, we can say it's diagenic, and we can see the autosomal dominant inheritance from one generation to the second generation, or else we see that unaffected individuals may have a child by the diagenic inheritance output, like an autosomal recessive trait. So the inheritance is complex, and of course the genetic etiology is complex. It's a unique repeat disorder, but unlike all the others that we know, it's not an expansion repeat, but it's a contraction. So there are, as I told, there are two different types of FSHD. One will be summing up to 95% of the cases, and FSH2 related with three other genes telling us about the diagenic inheritance is accumulating up to 5% of all the cases. Not only this, but we also see mosaicism. Mosaicism can be at two different types. One could be somatic mosaicism, and we know that de novo, sporadic, the first FSHD1 cases observed in the families are mosaic. 50% of the time they are mosaic, and there are asymptomatic cases. So mosaicism limited to different parts of the body, not affecting the target tissue of muscle, leads to asymptomatic cases with the somatic mosaicism. Although for other autosomal dominant disorders, there's a germline mosaicism that should be taken into account, but it is not reported for FSHD up till now. So for the history of what was the main points of the FSHD 1 and 2 diagnosis, the first one is in the beginning of 90s, that the gene or the locus responsible from the disease is residing at chromosome 4q. It was they thought it was a loss of a deletion, meaning that the area was contracted nowadays. And afterwards, in the later 90s, D4, Z4 repeat regions were well identified, and research moved on for the good of the diagnostic odyssey of the FSHD. Of course, because the inheritance pattern is so complex and there are lots of other issues running in the families, the counseling issues from a clinical geneticist view is very complex, sometimes can be very complex. So we know that very well that for autosomal dominant inheritance, the inheritance risk is 50%, but it is not easy to predict the phenotype. So there's an intrafamilial variability. So it is hard it makes it a bit complex for the genetic counseling. For the digenic inheritance, we know that inheritance risk is 25%. With these high risks of occurrence in the next generation, of course, we have to offer the families early invasive procedures at 12 gestational weeks. Okay, we have the fetal DNA to work on, but before it was very hard to have very solid results from the genetic testing, and it took a lot of time, and only very, very experienced, only 1 or 2 centers could take the responsibility of performing prenatal diagnosis. But now my colleague will tell you about the cutting edge technology. Optical genome mapping will make the world easier for the prenatal diagnosis. And as you can guess, for the FSHD type 2 diagnosis, we will have single gene variants, and this would be much, much easier to perform. And there is also the ethics. When we are talking about genetic counseling, there's an ethical issue, and the ethical issue is this: for asymptomatic individuals before the age of 18, it is not recommended. I mean, we should not perform genetic testing if they are asymptomatic, if they do not have any symptoms. So, of course, this was a diagnostic odyssey of the FSHD at Koç University Hospital. But of course, we have to we have to support our goal with the research projects. And the first project was a mini project, but it gave us a lot of support in the beginning. It was a university seed fund project, and we tried to work on the FSHD, and we gathered and we saw lots of patients, and we made the pedigrees, and we tried to get ready for the diagnostic and the research for more comprehensive research projects. And lately, like 5 years ago now, there's a European joint project in collaboration with Europe, Italy, Canada, Germany, and Turkey. This is a treatment, more of a treatment oriented research project, and we are one of the collaborators, and Serpil is the lead person for this research project, and it is about to finish, and so we will share our results with the health authorities and organizations and patients in this year. Of course, as we have told before, there are several different treatment options for the gene therapy. But today's topic is not gene therapy. Of course, everybody, for all diseases and for all patients, this is the future goal, to have gene therapy or gene therapy or mRNA-based therapy or other therapies that can solve the disease, the affected individuals' needs totally. So again, Serpil will tell you about the project that is running, European Joint Project. I do thank you for your attendance, and I know that, of course, today's lecture topic on the for the FSHD patients diagnosis and also the surgical treatment will be the main topics of today's webinar. And now I give the ground to my colleague who will be telling you more about the cutting edge diagnostic challenges in FSHD diagnosis.
My name is Serpil Eraslan. I'm molecular genetic lab supervisor at Koç University Hospital, and I also run the FSHD research and diagnostics unit. Thank you for your precious time. Actually, we are running out of it probably. I will try to summarize everything, which is very complicated and impossible to fit in 5 minutes. But my topics will start with the genetics of FSHD, and I will go through until what the future beholds. So we have, as Hülya mentioned, there is two types of FSHD. FSHD1 and FSHD2. What I want to talk about is what the pathology of this disease is, because in both cases, the genetic underlying genetic pathology is different, but the mechanism is the same. So the mechanism depends on DUX4 overexpression due to hypomethylation of the region. So it's a epigenomic differentiation which makes DUX4 protein overexpressed. And what is DUX4 actually? It's a transcription factor which is expressed in the cleavage stage embryos and only in cleavage stage embryos, and it should be silenced after this stage. Its function is to the zygotic genome activation of other genes. So the huge amount of functioning during this first stages of the embryo, DUX30 is the functioning gene. It's a transcription factor gene. And it should be silenced by DNA methylation, histone modification, and chromatin proteins. So what happens when it is not silenced, which is the case in the FSHD? It causes various number of diseases actually, which one of them is FSHD. And what it does is when it's overexpressed or it's expressed at all, it has a cytotoxicity, oxidative stress, and apoptosis on the cell. So let's talk about briefly about where DUX4 is. It's in the region of the D4Z4 repeat unit, which lies in chromosome 4, and it's on the telomeric region of the gene, of this region. And the allelic composition of this region also is very important, as I will mention later. In FSHD1 cases, this region is has a huge deletion. Normally, the region has 11 to 150 repeat units in healthy individuals. However, in FSHD, when the contraction happens, this repeat unit size decreases to 1 to 10 repeat units each patient. And as I mentioned, the allelic composition is very important because when it's the 4QA allelic composition, the DUX4 gene can be expressed. Otherwise, it will not be expressed, even though there is a contraction in the region. And in FSHD2 cases, the disease is due to the single nucleotide or copy number variations in the associated genes. And most of the associated genes are functioning, regulating the chromatin architecture of this region. So both disease types happen in the same region, but their genetic pathology is different. And in genotype-phenotype correlation, what we want to take notice of is that whenever the repeat contraction number is decreased, the severity increases. So, and in FSHD1, in both FSHD1 and FSHD2 patients, repeat number is very important. In 8 to 10 repeat unit borderline patients, as we call them, if there isn't any modifier gene activities, then we call it FSHD1 again. So between 1 to 10 repeat units, we always name it as FSHD1. However, in FSHD2, even when the repeat units is under 10, like 8 to 10, we can find some pathogenic variants in modifier genes, and thus the disease severity changes, and it can be called as FSHD2. And technical challenges is the main part of this talk, actually. So we are dealing with a huge sized region. If anybody works in the lab as a molecular geneticist will understand that we are talking about a 500 kb region, which is non-PCRable, non-real-timeable, no Sanger sequencing can be done, no fragmentation, so there has to be some other method. And the presence of permissive allele, which we call 4QA or 4QB allelic compositions, should be differentiated while doing the diagnosis. We also have another problem, which is the presence of a very homologous region on chromosome 10, which makes this diagnosis very complex, because we have to differentiate between chromosome 4, which the disease is associated with, from chromosome 10. And there is presence of complex rearrangements and somatic mosaics. So these issues really put some technical challenges on the subject, and we have to choose our method accordingly. And diagnostic techniques from southern blot, which is the oldest molecular technique used for all types of diseases, to high throughput technologies, it has come a long way. So just briefly, you can see the methods used for FSHD1 and FSHD2 profiling, and methylation profiling as well, because the disease is due to the epigenetic factors, epigenetic differentiation of the region due to the contraction or pathogenic variants. And we are using in our lab, we have used molecular combing technique, and we are now using optical genomic mapping technique for FSHD1 diagnosis. For methylation profiling, we are using bisulfite Sanger sequencing, and for FSHD, we can use Sanger sequencing or next generation sequencing technologies. I will go through this very fast. Just to give you an idea why southern blot was the gold standard technique up till now, but it's very cost effective. However, it's very labor intensive. It takes a long time to get the results, and molecular combing, optical genome mapping, and now long read sequencing have replaced southern blot technique, or replacing it as we go along. But the main problem is, unfortunately, the economical size of it. What we did, what we are doing in our unit, so we follow a molecular diagnosis algorithm. Since we have most of the cases are FSHD1 cases, we have to first see if there are any contractions in the subjects, and then we have to move on to methylation analysis, and then we have to check if we have any variations in the associated genes. And we have screened a total number of 133 individuals from 2019 to date. And actually, in this cohort includes the unaffected relatives who wants to know their genotype. So I have briefed my results to 125 patients which are symptomatic from 118 unrelated families. As you can see at the in this slide, we have in our cohort we found that 90% of our patients are FSHD1, and we have 4% of FSHD1 plus 2, and we have around 6% of patients which have non-contracted repeat units. And during our studies with this non-contracted group, we have found 2 patients with CAPN3 gene, which is associated to limb girdle. That's a differential diagnosis at its best, because now we are left with only 6 patients, which makes up to around 5%, which are still unsolved. And for the research project, we have already talked about it. I really don't want to go into it too much. However, it has been a collaborative study with 4 countries. Italy was the coordinator, and we had collaborators from Canada, Germany, and us from Turkey. And it's a VDR5 inhibitor, which was proposed as a therapeutic agent. And the study is near its end. And what has been done is in this ongoing project is the in vitro and in vivo studies for the safety and efficacy of VDR5 inhibitor. The project will finish by the end of this month, and the results will be shared as soon as they are available, probably at mid-2025. And from our research projects, we are now about to have 2 master's students which will have their dissertations in around a month. And what the future beholds is we have to refine the genetic and epigenetic assays and make them at lower test costs, and developing targeted therapies that looks for expression, and large-scale clinical trials and robust patient registries is also very important. Thank you very much for your time, and my special thanks goes to Türk Yıldızlı FSHD Foundation, which has supported us to form the BioNano optical genome mapping unit, and they will continue to support us with our diagnostic and research efforts. Thank you very much.
Thank you very much. It's as you already saw, our genetic department heard very about this very complex problem, and now Professor Oflazer will cover the following of the clinical presentation, and at the end we will cover the surgical options with Professor Eren and with Dr. Gedik.
Yeah. I will not go through this. The geneticist also gave you information about this, but you saw that it's not a disease in which the genetic testing is done. D4Z4 is contracted. It's not only that much. It's much more than that, and really needs expertise. So it's a slow progressive disease. Sometimes it shows fast progression, because FSHD is one of the myopathies which includes inflammation in muscle too. When there's inflammation and then weakness, we can get fast progressive phases of the disease. There is fatigue and there's pain, especially in the lumbar region. And some of these patients are misdiagnosed as disc herniation. And I saw several patients like this who had disc herniation surgery. And also during inflammation in a specific area, they have pain too. Cardiac problems are not very prominent in this disease, and respiratory problems are in the very late stages of the disease. But there are ophthalmologic retinal vasculopathy, which may go to Coats syndrome, or audiologic hearing loss symptoms in some diseases, especially at younger ages. Now, I will give you some examples from the Koç University Hospital Neuromuscular Center, which was established in 2019. This is the core neurological and pediatric neurological clinicians and our dear coordinator here at the center. We follow more than 2,000 patients. Total FSHD number in this group is 108. The infantile form, which started before 5 years of age, comprises 10% of the cases, and between 6 to 10 years as a childhood onset, we have 14.8, almost 15%. So in the childhood, 25 of our cases are in the childhood group. Usually the disease starts from adolescence up to 30 years. So we have some late adult cases too. We have 6 late adult cases in between these, among these 108 patients, which started after 40 years of age. And these are 6 patients, making 5.6. Now, typical FSHD, which starts in adolescence and up to 30 years of age, the main symptoms start from the face, even if the patient doesn't complain about this. This patient did not complain about the facial problems. When you examine, you can see it. But in the others, of course, they were aware of the facial weakness. In the upper extremity, you get weakness around the periscapular muscles, muscles around the scapula. Deltoid muscle is preserved in vast majority of the cases. And then you have the humeral muscles, which are biceps and triceps, that are affected. Because the periscapular muscles are weak, you get the scapular winging, which we will be talking in a minute. And when you look from the front side, you see this overriding scapula over there. Now, one thing is, these are 2 different patients. Because of the weakness of the muscles around the scapula, they cannot hold their arms up. You will see the mechanics of this later on. But if you do a maneuver like this, pushing the scapula to the front and down, then you let them use their hands, hold their arms much higher, which is the basis of the scapulothoracic arthrodesis, of course. Now with the trunk muscles can be compromised. So you can have a belly like this, and you can have hyperlordotic appearance. This is an MRI of a patient which shows the asymmetry of the FSHD, which is one of the main features of the disease. These are 2 iliopsoas muscles. One of them is almost fat, the other one is normal, as you see. It is a nice picture to show the asymmetry in these patients. And in the lower extremity, tibialis anterior and quadriceps muscles are the first to be affected. So most myopathies start from lower extremities like limb girdle or distal muscles. But FSHD is one of the most frequent muscular dystrophy which starts in facial muscles or has the onset, the first complaint in the periscapular muscles in the upper extremities. This makes it easier to be recognized even at the clinical level. So you can look at the patient and you can say that he or she has an FSHD. However, it is still challenging, especially when symptoms are very discrete. You have to have a clinical suspicion or an order of examining the patient completely so that you can think about FSHD. So what are the differential diagnoses? First of all, it is an asymmetric disease, and if the shoulder girdle is affected on one side, neurogenic causes of winging scapula are in the differential diagnosis. For example, long thoracic nerve, spinal accessory or dorsal scapular nerve, neuropathies, for example, or traumas. Some muscular dystrophies, mainly calpainopathy, such as called like FSHD without facial involvement. As Serpil said that in 3 of our cases, we found calpainopathy, but not FSHD. Pompe disease is said to have a phenotype like this. I have never seen this, but it is written. And some hereditary IBM mutations in the literature, they saw VCP mutations, for example, that looks like FSHD phenotype. This is an infantile case, a very, very severe case, who also has hearing loss as well. He has 3 repeat units in 4QA. When you look at it, it looks like more like a congenital muscular dystrophy rather than FSHD. I wouldn't say that he would have FSHD, but it's an FSHD. This is another patient, which is an infantile one, better than the first one, but it is still a severe case with scoliosis and hyperlordosis. This is an infantile case, but this is a very, very mild case, I should say. Now, there are some challenging cases too. This is a late onset case. When you look at her face and look at the asymmetry of the scapular winging, you can first think of FSHD. But you suspect about this. So it is a challenging disease, really. When you examine the face, he doesn't have FSHD features, although he has some here. At the 4QA allele, he has 14 repeat units. As you know, between 8 and 10, it is an intermediate form. After over 11, up to 150, it's normal. This can be considered normal, but we will check this with the optical genome mapping again, because we found another mutation in whole exome sequencing, which is a WUS, not a very pathogenic variation here. So we will work on her too. Now with this patient, his face looks like FSHD, but functions are all normal in the face. He has an asymmetric clinical picture, especially when he holds the arms. On one side, his trapezius muscle is atrophied, and you can think that this is a neurogenic disease, which was in the I told you within the differential diagnosis. We are still working on this, but the EMG is myogenic. So we started not with FSHD genetics, we started with whole exome sequencing in this patient. So we are waiting for the result for this. So there are some challenging patients too. This is the whole group of our neuromuscular center. And this is Koç University. Our clinicians, pediatricians, all pediatric and adult cardiologists, pneumologists, orthopedic surgeons, physiotherapists, all are there. We are together. And this is our website. If you are Turkish, it is in Turkish if you want to visit it. İlker prepared this website. We are in the time of developing the website now. Thank you very much. So now we come to the pathogenesis of winging. Which will be presented by Cemil Cihat Gedik, Understanding the Winging, Biomechanics of Shoulder Disability. Then İlker Eren will go on with the scapular fusion, weighing pros and cons. So we will get first the understanding, and then we will give you our experience. Please.
Can you see the presentation?
Yes.
Okay, great. So hello and welcome to Breaking Barriers in FSHD Care. I'm Cemil Cihat Gedik. I'm a fifth-year orthopedic surgery resident at Koç University Hospital. And I'm excited to share the insights on how FSHD affects shoulder mechanics and what that means for treatment. So I'll start with a brief overview of FSHD and its shoulder girdle involvement, followed by the periscapular muscles and the biomechanics of winging, leading to an introduction to the surgical solution. The basic anatomy of the shoulder and scapular motion is complex. The shoulder joint consists of four different articulations that are sternoclavicular joint, AC joint, acromioclavicular joint, glenohumeral joint, the normal shoulder, and this the interesting one is the scapulothoracic joint, which is not exactly a normal joint. And the scapular motion can be explained in different terms, but the most recent one is elevation depression, abduction adduction, upward rotation, and internal rotation. There's also the terms for protraction and retraction. So the periscapular muscles are the serratus anterior, trapezius, levator scapula, rhomboids, and the pectoralis minor. During shoulder movements, especially with overhead activities, these muscles stabilize the scapula against the thoracic wall, and their integrity is essential for the shoulder movement. When we look at the trapezius, there are three distinct parts. There's the upper, middle, and lower portions, and each of these have separate origins and insertions. They work synergistically with the serratus anterior and cause upward rotation of the scapula for overhead activities. It is one of the first muscles affected by FSHD. Serratus anterior causes scapular protraction and upward rotation of the scapula. It also facilitates overhead arm elevation. The dysfunction, which may result from the nerve palsies or the atrophy of the serratus anterior, causes medial winging. And FSHD also often results in wasting of this muscle as well. There's also the rhomboids and the levator scapula. Rhomboids cause scapular retraction, and levator scapula causes scapular elevation. The synergistic movements of these muscles are important in adduction, pulling, and lifting of the arm. FSHD also, again, causes wasting of these muscles as well. The shoulder girdle involvement, as Professor Oflazar mentioned, is characteristic and causes what is called scapular winging. The periscapular and pectoralis and the biceps and triceps are usually affected, whereas the deltoid, rotator cuff, and the forearm muscles are spared. So the MRI studies also show that the most severely affected muscles in the upper extremity are the trapezius, teres major, and serratus anterior. This scapula normally acts as a stable base for shoulder movement, and synergistic and harmonious contraction of the periscapular muscles stabilize the scapula for upper extremity motion, especially for overhead activities, and the atrophy of these muscles result in scapular winging. The winging pattern in FSHD can be both lateral and medial. So the lateral scapular winging caused by the trapezius paralysis or the atrophy, and the medial scapular winging is caused by serratus anterior paralysis or atrophy of this muscle. So FSHD is mixed, as both muscles are affected. So again, different winging patterns are depending on their remaining stabilization function. We recently published a study that explains the classification of scapulothoracic abnormal motion. This falls into category 5, and it is the, again, combined atrophy of trapezius and serratus. So when there's a function in deltoid and we don't have the periscapular muscles, the deltoid pulls, and as the scapula cannot be kept in place, it causes winging. There's the deltoid is important because it is also used in staging, which is used for the which guides for surgical options. So the solution is to stabilize the scapula again, so that the patient can reach overhead, which is shown here by Professor Demirhan. And so instead of having his hand on the scapula, we can fix the scapula to reach overhead. Thank you for your time.
Can you see the presentation?
Yes.
Yes.
Yes, perfect. Okay, now I will try to summarize not only the indications, but try to explain what happens to a patient after scapulothoracic fusion. And we will talk about problems associated with a bit. So when we are talking about scapula, the delicate balance of muscles are critical. So when we have an imbalance for any reason, we end up with a scapular dysfunction. You may call this scapular dyskinesia, you may call this scapulothoracic abnormal motion, you may call this scapular winging, but at the end, the problem is the balance of the muscles around the shoulder and its association with the glenohumeral joint. So the solution is usually the rehabilitation, increasing the coordination, or we do releases to weaken one side, or we may do transfers to strengthen one side. Scapulothoracic arthrodesis is a complete player here. We are not talking about the balance anymore when we do the arthrodesis. So we are canceling the need for balance and we are fixing all the structures together. So I will briefly go over some non-dystrophic conditions. I will explain why, and we will go over mainly on FSHD and try to explain what we sacrifice, and we'll go over techniques and some complications. So why am I talking about non-dystrophic scenarios? Because we sometimes get referrals with other causes of scapular winging referred us to make arthrodesis, but this is not the best solution for this patient, particularly in patients with fully functional but uncoordinated muscles, which is classically called dyskinesis, are never candidates for arthrodesis because balance can be restored in a way in these patients. There are some nerve injury scenarios. So there's one muscle affected, it's not functioning, and so one function related to that nerve is affected. And there are patients with a previously failed surgery related to scapular muscle transfers. So in these specific nerve injury scenarios, these are very well known, like trapezius, spinal accessory nerve, long thoracic nerve palsy, which leads to serratus anterior palsy, rarely dorsal scapular nerve palsy, which leads to rhomboid weakening. So these are all very well clinical scenarios, and there are well-established transfer options. So we are not thinking about arthrodesis as the first line in these patients. So when can we perform arthrodesis in these conditions? Not as a first line, but when the transfers or releases or other treatment options fail, it can be considered as a salvage procedure. So, of course, we are sacrificing something, but if we cannot restore the balance anyway, we don't, any tools are not left, so we can continue with arthrodesis with some predictable limitations and outcomes. But pros and cons, of course, has to justify. FSHD is a whole another story because it is used as a first-line treatment in selected patients. This is critical. So why we are not doing muscle transfers in these patients? Because all the transferable muscle options are affected. As you had mentioned, it's not just trapezius, it's not just serratus anterior. All the periscapular and most of the shoulder muscles are affected. So we don't have a transfer option. And it's a progressive disease. So this is not a good scenario for transfers. And why fusion is successful in FSHD? That's an important question as well, because it's not successful other muscular diseases. In FSHD, deltoid and rotator cuff muscles are mostly preserved. So we can rely on this and continue with scapulothoracic fusion to get some function. So the most important first step is selecting the right patient. So we developed this grading staging method to identify the best candidates. In grade 0-1 patients, these are very mildly affected patients with sometimes just only diagnosis without any muscle atrophy. In grade 2 patients, they can elevate their arms over 90 degrees, and that's why they have mild winging. Some scapular stabilization function is preserved, and they can usually reach overhead levels. So they don't require any surgery for their daily activities. In grade 4 patients, some strength of the deltoid is lost. So we are not benefiting as much as others in these patients. And the most severe ones, we don't have any deltoid, we don't have any scapular stabilization, but you don't see any winging because there is no motor function of the shoulder, so they don't benefit. So in mild patients get worse with scapulothoracic arthrodesis. On the other end of the spectrum, they don't benefit. So we need the best candidates. These are the grade 3 patients where we have complete periscapular atrophy. So you see serious scapular winging in these patients, and they have good deltoid function. So when you stabilize the scapula or the thoracic wall by yourself, by your hand, you can see that patients can reach above head levels. Without stabilization, they remain below 90 degrees. So these are the best candidates for surgery. First, we need to understand what we are sacrificing with scapulothoracic motion. This is a very interesting study. Normally, it is very difficult to do a motion analysis in scapula because you don't have any fixed landmarks. It moves freely under the skin, so you cannot do a motion analysis with classical methods. But in this study, they used bone pins to do that. So we can rely on this one. So when we, in x-axis, you see the humerothoracic elevation in all graphs. So as you start moving your arm, as you start elevating your arm, scapula internally rotates. For some studies, it's external. You start seeing tilting, posterior tilting, and upward rotation. These motions start immediately from the beginning of the arm elevation and continues till the end of the motion. So it's not just at the end or beginning it. So with arthrodesis, we are completely sacrificing all these scapulothoracic motions. What is left? It's only the glenohumeral motion. So this is the most important part a surgeon, a doctor, or a patient should understand about scapulothoracic arthrodesis. So according to this study, glenohumeral motion is 85 something, 86 degrees. So according to this studies, this is the one we left after scapulothoracic arthrodesis. This is one of our patients. I think he was operated 8 years ago, something like that. So you can see that he can reach not just overhead levels, he can reach ceiling. His job is painting ceilings. So if you look at closely his trunk and shoulders, it is clearly over 90 degrees glenohumeral motion. It is not 160 or 150. That's also clear. You can notice there is a very visible trunk compensation and very visible arm motion compensation as well. So the benefit of scapulothoracic arthrodesis is not just the motion itself, but we are bringing strength to the arm and allow patients to compensate better their disabilities. So, for example, this is another patient, the right one. Before surgery, he has 45 or 50 degrees of elevation, and after arthrodesis, you can see that his elevation improved very high overhead levels. So some years ago, we published our series in JBGS. This is still one of the biggest series in the literature. We were able to show that elevation, forward flexion improved from 60 degrees to 124, and abduction improved to 50 to 100 degrees. So on average, patients are improving. So we understand that when we do a scapular fixation, it's the glenohumeral motion that is left. So it becomes the humerothoracic motion, and we are canceling the other scapular motions. So with some observations and according to some data, I can say that in the early phases of the surgery, so we, of course, get an early acromial contact because of the acromion is fixed and humerus elevates as patients want to elevate their arms. But as they continue rehabilitation, they start to exceed these limits and reach overhead levels with maybe with better glenohumeral laxity, with maybe better compensation methods, and so they reach higher levels, which appears to be permanent. So we are talking about elevation, but there's something I want you to notice as well. So this is one of our patients. You see that her arm elevation is around 60 degrees before surgery with classical scapular winging on the left side, you can see. So 1 and 2 years after surgery, you can see she can reach now over high overhead levels. But now look how she is elevating her arms. As she wants to forward flex, there is an involuntary abduction. Because of the glenohumeral joints limitations, it tends to elevate at the scapular level. So she is moving her arms to side as they want to flex forward. So the reason is, so we talked about the limitation of glenohumeral motion. So that's the reason. But the other important reason is probably the weakness of anterior deltoid, because before surgery, their shoulder shoulders are anteriorly tilted and protracted. So they never use anterior deltoid in their life. This also causes posterior capsular tightness because of the scapular position. So as we take their scapula back, now they start experiencing weakness of the anterior deltoid, and they start understanding the posterior capsular tightness. So these become the main aims of the posterior post-op rehabilitation. So we start this around 4 or 5 months as we reach a successful fusion, and continue at least for several years. So Professor Demirhan also mentioned, this is not a fixing scapula is not a new idea. It is really a century-old surgery. When it was first proposed, results were terrible, of course, because of the surgical technologies they had. But in the last several decades, so the two techniques become favorable. One is the one we use, that one we described, using multi-filament cables to create separate fixation point. The other one, which is also practiced in several centers around the world, is using cables and plates to increase the contact area. So these two techniques are currently practiced. So I will show you some steps of the surgery. Now the patient is laying prone. You see the scapula. This is right scapula. We are looking from the left side, and we are looking to the medial border of the scapula. So you can see the yellow tissues here. These are not subcutaneous tissues. These were trapezius, rhomboid, serratus anterior ones. Because of the atrophy that we expect from these patients, the muscle tissue completely became fatty tissue. So this is probably will be the reason why we will not have a perfect recovery maybe with drugs in the future. But what is interesting is the next stage. As we retract the now fat tissue, which was muscle once, we come to the infraspinatus muscle, which is a couple of millimeters adjacent to the first muscle group, but it looks completely normal. So this is what is unique with this disease, and this is what enables us to do this surgery. So at these stages of the surgery, we prepare the scapula, then we prepare the ribs. So you see the 2nd to 7th ribs. This is usually these are what are usually used. Then we pass these strong cables beneath the ribs and fix them to the scapula. At this stage, bone graft obtained from iliac crest is also used, because we are trying to fuse two uneven surfaces here. So several years ago, we did a review of the literature. This is an unpublished data. So there were, at that time, there were 400 something cases. Probably it's now around 500 cases in the literature now. Most of the operated patients are young adults. And if you don't count the older surgeries done with screws, which fails commonly, they are either single monofilament cable method or plate plus sarclage or cable method. And most of the surgeons prefer using grafts, which is our preference as well. In the literature, it is reported to fix 3 to 6 levels. We recommend fixing 5 to 6 levels. And immobilization varied a lot. It is 6 to 18 weeks in the literature, but what we are doing now is 8 weeks of immobilization using a sling, but it's not a complete immobilization. We allow patients to perform tabletop activities. So complication rate is very high. If you take to the literature, it's almost 1 complication for each case. So as we mentioned about complications, let's try to summarize what can go wrong as well. There are some things. So we classify these into 2 categories first. there are scapular complications related to fixation, and there are pulmonary complications related to lungs. These can be minor, which requires just follow-up, and major complications, which requires an intervention. So the main group, one main group is pulmonary complications. It is very common, actually. So in almost all patients, we see small minor atelectasis or pulmonary effusion. We don't count it as complication. It's something expected because these patients have chest wall pain. These patients avoid mobility with poor inspiration, and maybe we are causing a pleural irritation as well. So you see, this is very common with postoperative follow-up. It looks perfect in the first day. So you start seeing effusion in the second, third days. It starts resolving in the fifth day, and in a week, it becomes completely normal. If patients are asymptomatic with normal SO2 levels, we just do pulmonary exercises and expect spontaneous recovery. But if it's progressive with symptomatic shortness of breath or lower SO2 levels, then these patients may need a chest tube. So a consultation with thoracic surgeons may be required as well. We may have pneumothorax. So it's always an intraoperative issue because we are damaging the parietal pleura here. There's a nice trick that we described during the surgery. After passing all the cables, we submerge the surgical area with saline and ask anesthesiologists to ventilate the patients with higher pressure. So if you see these bubbles coming out in some level, that it means we damage the pleura at some levels. Then immediately we put a chest tube, which heals in a couple of days eventually. On the scapular side, so in our series, we saw rib fractures, we saw scapular fractures, complete failures like you saw on the right side. So these probably have a learning curve because we are doing this surgery for the last 20 years, maybe more than 20 years. And these belong to more early phases of the surgery. So in the last 10 years, I haven't encountered one. So probably it has a learning curve. There are some late scapular fractures as well. So it's probably stress fracture with just lateral to the fixation point. Implant irritation is relatively common compared to other ones, but easy to manage. There are non-union patients, but interestingly, they do continue doing well. And most devastating complication is maybe the brachial plexus palsy. So in our series, it was 26% the complication rate, but there are minor complications are counted as well. But as I mentioned, so these mostly belong to the early years of the surgery. So we don't see some of these anymore. So probably with experienced hands, it's less than this. I mentioned about plexus paralysis. This is like a landmine. So you know it is there, but you don't know when it is to happen. You don't know which patient is at risk. You don't know how to avoid it. Luckily, it is rare. So in the literature, there are several case reports. We had one patient as well, which recovered mostly, hopefully. It may be plexus, it may be radial alone, all reported in the literature. So as a level 5 recommendation, it is recommended to do a clavicle osteotomy, but it's coming from Sprengel's deformity, so it doesn't belong to scapulothoracic arthrodesis, but we don't have any studies, we don't have any evidence here. So if you encounter one postoperative, we do a clavicle osteotomy to relieve the pressure on the plexus. This last year we published this study. We asked a simple question. So there are complications. So is it possible to decrease the number of operated rib levels? The aim was if we decrease the operated levels, then there will be less pulmonary complications. But on the other hand, we cannot risk the fixation quality. So which levels can be removed? So for that, we created a 3D model of scapulothoracic arterioles, and we did a finite element analysis. It was interesting. In the beginning, we were planning to remove the T2 level because it was the most difficult one during the surgery. But the study showed us that it is an important level. So it's staying. And when we can remove the levels in between, but you increase the adjacent loads. So it seems 5 to 6 recommendation stays. And what was interesting was, as we removed the clavicle, did a clavicle osteotomy to the model, all the load on all the levels increased drastically. So the clavicle osteotomy should be done very carefully in selected cases. So after this study, we continued what we are doing. What is important after surgery is pain management. We understood this in the late years. So there is a simple equation. When you have less postoperative pain, you get a better chest mobility and less pulmonary complications. That's simple. It is a basic rule of all thoracic surgeries, actually. So we did that. We tried 2 different methods. We put a erector spinal catheter, erector spinal plain block. That's a plain block, which was described before. Not for STA, but for other thoracic surgeries. And we tried dorsal scapular nerve and long thoracic nerve blocks as well. And now we are continuing to use erector spinal block using a epidural catheter, use patient control analgesia, and continue for a couple of days so patients can start their pulmonary exercises immediately. So to summarize, in non-dystrophic patients, we avoid doing scapulothoracic fusion. It is very, very rare and only done as a salvage procedure. The best indication is clearly FSHD. So until we find a cure, maybe we will not do this surgery in the future. We don't know. But patient selection is critical. What is the ideal method for fixation? So the modern techniques seem to be functional, but ideal scapular position, which affects the function, still has to be questioned. So we are continuing biomechanical studies on this topic, and some focus after arthrodesis is required for rehabilitation as well. So we only have glenohumeral motion after arthrodesis. So that's all we have. Now we have to improve it in a way. Thank you for listening.
Thank you, Ilker. And this was actually a brief summary about the surgery and about the benefit of the patients. And this is a new way for this kind of patients until the genetic and the neurology can find the cure for this disease. And during this period we are happy to help some of the FSHD patients in this way for your daily life comfort. Dr. Oflozer?
I thank you, all of them, all of you. Sorry. I think it was a very interesting symposium, apart from the clinics, which is very well known actually. But both of our groups, the genetics group and the orthopedic surgery groups, are doing very unique things. I wish it was. I hope we can have some questions about this.
Yes, we're on the chat. Yes, we have some on the chat.
Some on the chat, some on the question and answers. But these questions are about the drug trials. So at the beginning, I told you that this is out of our focus today. There is one question which says, what was the oldest patient that was operated on? Do the surgeons have a specific age limit for the surgery?
Maybe I can answer this question.
Mhm.
So there are several considerations on this topic. First, we are trying to achieve a successful fusion. So two bones has to fuse each other. So for that, we need a good working biology. That means we need a young patient. Second, I mentioned about the importance of rehabilitation after surgery. Patients should cope with the needs of the rehabilitation, continue with the program, which takes some time. These two are much better in younger patients than the older ones. So today we are considering surgery before the age of 40. There are several patients that we operated after the age of 40, but so fusion problems are higher in those. Pulmonary complications cannot be tolerated better than younger ones. So it is best to do at young ages. Usually our patients are at 20s, so which is the best age, I think, for doing such a fusion surgery. Maybe we can extend this question. Who can be a young?
Yes.
What is the youngest limit? Now, for that, we need a good scapula with adequate bone stock. So we don't operate patients younger than age of 15. I think we had one 14 age patient, but as a rule of thumb, before age of 16, we are trying to avoid surgery, wait for the surgery, and continue with rehabilitation. And one important remark about young patients. So if a patient's symptoms start early, like age 8, 9, 10, or younger than that, maybe they are not good candidates for surgery, because this means they can rapidly develop more severe symptoms. They can be infantile form or other younger forms. So they may lose their surgical benefits in very early ages. So we are avoiding doing at those ages and see how patients are doing.
Thank you. Any other question or remark?
There's one question about surgical technique, about hemothorax. Yeah, that's true. But so attendee asked if hemothorax can be seen because wires are very close to the intercostal vessels and nerves. But that's a very good point, which is also maybe related to chronic pain, which is also mentioned in the question. So yes, it's important. So if we are not careful about veins and arteries at intercostal level, patients may continue bleeding. But fortunately, they are very easily visible during surgery at the cable passing stage. So we can see if they are injured, we can cauterize or do any other methods to stop bleeding there. So theoretically, yes, hemothorax can be seen. Did we see? Yes, we had patients with hemothorax, but it was possible to manage with chest tubes. And probably the reason is intercostal vessels. But if with a careful surgery, it is possible to stop bleeding from there. And chronic pain related to intercostal nerves, if if we don't dissect the nerve and keep it out of the fixation circulage, yes, we may have chronic pain, at the chest wall pain, but fortunately, we didn't have with
It's
those.
very rare, I think, huh? May I have a
Yes,
question?
yes, of course.
Now, they can hold their arms with glenohumeral movement, but in daily life, what cannot do they do?
Well, what are the
What are the things
difficulties?
they
Practical
cannot do?
difficulties.
Hmm?
So they can elevate their arms, but there is a involuntary abduction. So reaching overhead levels in front of the patient, which is in adduction, AD adduction, is difficult for them because of weakness of anterior deltoid, because of capsular tightness, and because of glenohumeral limitations. That's why after 6 months, we start stretching exercises and we focus on posterior capsular stretching. So they can adduct their arms and reach contralateral shoulder, reach contralateral face. So we are trying to increase the glenohumeral motion, but this is what is difficult, reaching directly in front of the other side at overhead levels.
What about clipping the bras in women patients?
Yeah, that's another possible limitation, because in female patients it's necessary. And because of the winging, pathological winging, they can reach even higher levels in their back, these patients. A normal male patient can reach T12 level, not higher than that. A normal female patient, normal female person can reach interscapular levels. But these patients can reach their necks because of their winging, pathological winging. So of course we are limiting that. So they go from neck to lumbar or T12 levels. They require some rehabilitation for clipping bra, and some patients may have difficulties. But clipping bra is a combined motion. It's not just shoulder. It depends their hand status. It depends on forearm muscle status. It depends on arm muscle status. So if they have good strength in the remaining arm, yes, they may do that. But if they weakness with others, they may have difficulties.
Yeah, there's a variability in that too. That's why I asked it. So Ayşe Nursu asks something.
It was also another question about the suffering of the tearing of the cables. Yes, it can, if there is a non-union in any level of the between the scapula and the ribs, then it can be. We saw that, and we can remove easily this broken cables, and this is very mini operation to remove this, and because we have enough level for union, also union for scapulothoracic fusion. And that reason we saw only how many I cannot remember now. It's not so many, but the 3 or 5 levels, 3 or 5 patients that we have to remove this type of this kind of tearing of the cables.
Okay, thank you. So Ayşe Nur asks, she thanks to us for the talks. I would like to ask about the long-term outcomes of the patients with STA. It would be valuable for us to have some information about the duration of the well-being of FSHD patients in terms of arm movements after surgery. So your follow-up period maybe. What is the longest?
İlker, can you open your you are unmuted.
Sorry. Our oldest patients are now have 20 years of follow-up. So you also followed these patients as well. So that's what we notice is patients reach their best state after the first year, and they tend to stay there. It's probably because the progression rate of the disease is so low, and status of the deltoid is somehow preserved in the long run. Since we don't need any scapulothoracic stabilization function anymore, so if patients keep their deltoid strength, they continue with their function.
Mhm. So after STA, physiotherapy becomes more and more important, I think, for those patients. Regular exercises, huh?
Yeah.
True.
Okay, what else? Has any of the patients suffered a tearing of the cables? If so, were they operated on again?
I think Professor Demirhan answered that question, right?
Ah, okay.
So
Could you
it's
please
easy
repeat?
to
Yeah,
remove
okay.
cables.
You did, yes.
Yes. Mhm.
Mhm. I don't have a question, Seto, but the videos after the surgeries showing the gain of function were very impressive. Congratulations to the surgeons. Okay.
Thank you.
Say thank you.
Thank you.
As to any other. Yeah, that's it, I think. So should we close now? What do you think?
If there is no question anymore, we are here, and Professor Oflazer is actually the leader of this group and this muscle disease center, and I think it's we will be very happy to help these patients, and the new aspect, not only in surgery, although from the genetic part, and also the multidisciplinary collaboration with other disciplines. And I think there are very, very few centers that can reach this point, and we are happy to reach this point in the Koç University and also in our country. Thank you very much to all.
Thank you. If you take one part from this group, it will not be working very well, actually. So we are doing clinical research, lab research, molecular research, all of them. As you see, we do the surgery, but we not only collect and follow the patients, but we bring out information from their situation as well. So I think this is valuable. But the most valuable thing is our audience. Thank you very much for being with us in this webinar tonight. Good night.
Thank you. Thank you. Good night.
Thank you.
Thank
Good
you.
night.
Thank you.